We are waiting for Ramakrishna Reddy.
Oh, yes, sir.
As soon as he comes, we will start the meeting.
So, sir, anyone, any 2 minutes we have, anyone want to share about your experience in the abdominal aortic aneurysm in the past?
Yeah, Gopinath should tell. Yeah, good evening, Gopinath.
Because many people are joined, rather than wasting time, we can have some kind of.
Yeah. We can interact with ourselves.
Yes, sir.
Yeah, I know, but basically most of the aneurysms, abdominal aneurysms were managed by our vascular surgeons. So essentially, it is unless if you look at it from the elective or the emergent condition, obviously most of it would have been as an emergent situation, generally ruptured triplets. So most quite a lot of these patients, we had issues because it was a tamponade effect on the abdomen with a ruptured triplet. So it had to be generally a very safe induction and quick interaction by the surgeons. As soon as the abdomen is opened, they used to collapse. So in those terms, I think very, very interesting to keep you on your toes. And so we normally used to do all our monitoring prior to induction or in the ward or in the emergency department. Vascular surgeons, all vascular surgeries are very important and high risk.
Good evening, everyone.
Good evening, Ramakrishna. Waiting for you.
Welcome to ISA Telangana Webinar number 42. We have been continuing this since 2020. I welcome President ISA Telangana, Dr. Ratnakar sir, and Dr. Chakrarao garu, IRCF chairman. Namaste sir. Dr. Deepra sir, Dr. Gopinath sir, and Dr. Ranjit Karthikeyan sir, and Dr. Nishant Kumar sir, and all postgraduates. So I request now Dr. Shyam Sundar to begin the webinar.
Yeah, thank you, sir. Good evening, all. Today's webinar is, we are having 2 topics. One is anesthesia management of abdominal aortic aneurysm, and second one is pulmonology intervention, management of for pulmonological interventions. The first talk will be given by Professor Ranjit Karthikeyan, who is my teacher, and he is right now professor in the Sri Ramchandra Institute of Medical Sciences, Chennai. And he is also founder and for the Raw Online, which is a very popular both app and I think it's an educational website. Many of them are aware of that. I think few of them are. I request a few who is some voices I'm getting. Can we mute who is not speaking? I request all to mute because we have a lot of disturbance here. Yeah. Thank you. The first talk, I request Dr. Ranjit Karthikeyan sir to present his talk.
Yeah. Good evening, Dr. Shyam. Actually, I am very tense because Shyam said I am his teacher. Actually, he was my teacher, actually. Because anything I asked, Shyam will be the first person to argue, why are you doing this? Why are you doing that? Like that. Anyway, I'm really tense to give a talk in front of Shyam, actually. Thank you, Shyam, anyway, for inviting me for the ISA Telangana. Also, I thank Professor Ratnakar, Ramakrishna Reddy, and Dr. Chakrarao and Gopinath sir for being there. What I have done is I have recorded the talk in the studio, so we won't waste much time in live presentation. I'll play the video, then I will be available for the questioning answering session. Mohan, you can play the video, Mohan. Yeah. Intelligent man of 19th century. Start from
Einstein.
beginning, Mohan. Hi all, welcome to Raw Online. Today we are going to deal with one important vascular pathology, that is abdominal aortic aneurysm. Coming to the history, the most intelligent man of 19th century, Einstein, had a very good relationship with the abdominal aortic aneurysm. In 1948, he was shifted to the operating room for the diagnosis of intestinal cyst. When they opened up the abdomen, they were surprised to see abdominal aortic aneurysm instead of a cyst. So what they did is they wrapped the aneurysm with a cellophane so that the aneurysm doesn't expand. What happened in the next 6 years? Einstein had a lot of abdominal pain after 2 or 3 years post surgery. Then finally he died at the age of 76. The cause of death was a burst artery. That is nothing but the aneurysm gave way and ruptured. From Einstein's story, we have three major points. First is ruptured aortic aneurysm is almost always fatal. Next, you can't wrap up an aneurysm. The aneurysm will expand and definitely it will blow out. Third, it is an incidental finding. With this background, let us move into the anatomy of aorta first, then we'll move into abdominal aorta. The aorta originates from the left ventricle as the ascending thoracic aorta. Then it continues as arch of aorta where it gives rise to cerebral vessels. Then continues down as descending thoracic aorta. It pierces the diaphragm and enters as abdominal aorta before bifurcating into iliac artery. This is one of the largest vascular structure in the body, supplying major organs of the thoracic and the abdominal cavity. About 1/3 of the aneurysm arises from the thoracic aorta and 2/3 arises from the abdominal aorta. Of the abdominal aorta, 20% is suprarenal and 80% is infrarenal. Whenever you talk about abdominal aorta, you should look at the vascular structures which comes from the abdominal aorta. The first and foremost is the celiac artery, which supplies majority of the intestine. Then little bit down you have the superior mesenteric artery, which also supply the intestines. Then little down you have the left and right renal artery. Below it you have the inferior mesenteric artery. These are all the major vascular structures which come from the anterior part of the abdominal aorta. Why you have to know about this anatomy? Your intervention of aortic aneurysm will depend upon this anatomy. Few things, few measurements are very important in the anatomy. The first and foremost is the distance from the renal artery. Okay. If it is infrarenal, you have to measure the distance from which the aneurysm rises from the renal artery. Next is the point B, which is the normal diameter of the aorta. Because this normal diameter, you have to compare with the diameter of the aortic aneurysm. That is the third measurement. Another important thing is the distance from the iliac artery, whether it is located too superior to the iliac artery. These are the various measurements you have to look in the CT angiogram. Now coming to the definition of abdominal aortic aneurysm. It is nothing but an abnormal and irreversible. These adjectives are very important. It is not normal and it is irreversible. Dilatation of the focal area of abdominal aorta to twice the diameter of normal arterial segment. The normal artery, normal aortic diameter is around 2 centimeter. So aneurysm is invariably between 3.5 to 5 centimeter. Another important character is it should involve all the three layers of aorta, that is intima, media and adventitia. For in pseudoaneurysm, it may involve only one layer, but here all the three layers will be involved. Now coming to the classification. Here you have three major classification. One classification by location, another is classification by shape, and third is classification by size. Now classification by location. The first and foremost is called adrenal. Here it is just above the renal artery. This is a left renal, this is a right renal, and it is above the renal artery, which is called adrenal. In other words, it is called suprarenal location. The next one is adjacent to the renal artery, which is called juxtarenal. And if it is below the renal artery, it is called infrarenal. This was the classification of abdominal aortic aneurysm with regard to location. Now coming to shape, it can be fusiform local. This is fusiform diffuse, a diffuse fusiform dilatation of the abdominal aorta, and this is saccular form of abdominal aortic aneurysm, and this is eccentric form of abdominal aortic aneurysm. This is the classification based on shape of abdominal aortic aneurysm. Now coming to the other classification, which is based on the size. It is going to be small between 3 to 5 centimeter. It is moderate when it is between 5 to 6 centimeter, and it is large when it is between 6 to 7 centimeter, and it is very large when it is greater than 7 centimeter. Why you have to know the size? As the size become bigger, the rate of expansion and rupture is going to increase. For example, if the size is going to be greater than 7, here you can see the rupture rate is almost around 20 to 40%, which is very high. Another important thing based on size is how you are going to base your intervention. Let us assume that you have a aneurysm diameter of less than 3 centimeter, between 3 to 5.5 and greater than 5.5. If it is less than 3, what you have to do is just wait and watch. No surveillance is required here. If it is between 3 to 5.5, you have to look at the rupture risk and the operative risk. If the rupture risk is low and the operative risk is high, you go for surveillance. If the rupture risk is high and the operative risk is low, go for intervention, either endovascular placement of stent or surgical repair. If the aortic diameter is greater than 5.5 centimeter, then you have left with no option, go with the intervention at the earliest. Now coming to risk factor. Here you can see on the x-axis the age, on the y-axis the incidence of abdominal aortic aneurysm. Here you can clearly see that as the age progresses, the incidence steadily increases. At age of greater than 65 years, the incidence is almost 8.6%. Another important risk factor is male sex. The incidence of abdominal aortic aneurysm is 4 times greater than that of females. And coming to smoking, the incidence of abdominal aortic aneurysm is almost double than smokers than non-smokers. These are the 3 major risk factors: male sex, elderly population, and smoking history. Apart from that, you have various other risk factors like atherosclerosis, cerebral vascular disease, coronary artery disease, family history, history of hypertension, history of aneurysm on a peripheral vessel, obesity, and peripheral artery disease. These are all the various additional risk factors for aneurysm. Now coming to etiology. Why the aneurysm is very common in the infrarenal part? You have to understand that different part of aorta have different embryologic origin. That means the arch will have a different origin, thoracic aorta will have a different origin, and the abdominal aorta have a different origin. But what happens in the infrarenal part? It has a poorly developed vasovasorum, which means there is dedicated blood supply to the vessel wall alone. Infrarenal artery also relies slowly on the nutrition deficient from the aortic blood that causes from the abdominal aorta, not on the proximal part. This makes the infrarenal more prone to ischemia and has impaired repair potential. Another important is the infrarenal aortic valve has fewer lamellar units than other part of the aorta. This makes it less elastic and less ability to distribute the stress. That is the reason 80% of the aneurysm is infrarenal. Coming to other etiological factor, first and foremost is autoimmunity to various infections like chlamydia, mycoplasma pneumonia, helicobacter, human cytomegalovirus and herpes simplex virus. Here the antigen which is produced resemble the local proteins in the abdominal aorta. To this antigen, antibodies are produced which will tag the abdominal aorta for destruction of T lymphocytes. Then autoimmune mediated destruction of aorta can happen. Coming to the most important causative factors, smoking, genetics and atherosclerosis. Here the mechanism is unclear, but there is a subacute inflammation of the aortic tissue. The cytokines are released and the immune cells are recruited. And what happens is infiltration of the vessel walls by lymphocyte and macrophages and production of enzymes that destroys the elastin and collagen proteins. This elastin and collagen is very important to maintain the integrity of the vessel wall. If it is destroyed, automatically there is going to be degradation of aortic connective tissue which leads to aneurysm. The most important etiological factor is going to be hypertension. Here there is going to be pressure on aorta and other vessel wall which causes biomechanical stresses on the vessel wall. Coming to elderly age group, there is progressive deterioration of aortic structural integrity over lifespan. As you go older, the integration is lost and this makes the aorta susceptible to damage. In connective tissue disorder, there is structurally abnormal protein or the protein organization in aorta will be disorganized. All this leads to loss of smooth muscle cells and thinning of tunica media and distraction of elastin in the media. So your aortic tensile strength is coming down. So whenever aorta is put to stretch, it expands, dilate and causes an aneurysm. Here you can see the blood is coming from the left ventricle going via aorta to the iliac artery. Now if you look at the lumen, the blood vessels flow without any problem. If you look at the vessel wall, this vessel wall understanding is very important for aneurysm. This is the lumen, okay. This is the intima. This part is the media and this part is the adventitia. And here these are the endothelial cells which are located at the intima, which is very important to maintain the integrity of the vessel wall. This is the internal elastic lamina. This part is the internal elastic lamina and this part is the external elastic lamina. And these are smooth cells and these are all collagen and elastin fibers, smooth muscles. And these are elastin and collagen fibrils. Normally this elastin and collagen fibril will make a smooth arrangement of the vessel. And this part is the external elastic lamina and this is called the vasa vasorum which is located in the adventitia. This part is very important because when the aneurysm dilate, this vasa vasorum has nerve ending and contributes to abdominal pain. Now if you look at what happens in the aneurysm, now blood flow across the aneurysm. Usually blood flow won't be compromised unless there is some thrombus to occlude. So the blood vessels flow across the aneurysm also. Here the blood flow is there. And if you look at the vessel wall, there is going to be infiltration with macrophages and neutrophils. Macrophage, neutrophils, complement activation and cytokine activation can happen. And here you can see the endothelial cells disturbed. Your internal elastic lamina, external elastic lamina architecture is disturbed. Smooth muscles have decreased in number and the elastin and collagen fibrils are degraded. And what happens here is the vasa vasorum dilates too much and patient will have severe pain. This is the pathogenesis of abdominal aortic aneurysm. Now coming to symptomatology. Most of the time, 70 to 80% of the cases, it is totally asymptomatic. It is an incidental finding in some abdominal imaging modality. It can be symptomatic in 20 to 30% of the cases, and another 10 to 15% of the cases, rupture can happen and can lead to acute hemodynamic compromise. Coming to symptomatology, the most common symptom is going to be intermittent stabbing sensation in the anterior part of the abdomen, or a intermittent dull backache, throbbing sensation in the posterior low back. Sometimes the thrombus in the aneurysm might migrate, and it might migrate to renal artery causing renal ischemia, or it might migrate to the femoral artery causing distal limb ischemia, sometimes to the superior or celiac vessels and cause mesenteric ischemia. So they can be renal ischemia, distal limb ischemia, or mesenteric ischemia. Coming to rupture. Here, two types of ruptures can happen, peritoneal and retroperitoneal. This is peritoneal rupture. That means it ruptures from the anterior part. Here you can see the vessel gets ruptured. But anterior peritoneal cavity doesn't have much space to occupy. The abdomen, anterior peritoneal cavity is very much limited. So once it ruptures, the patient will have a sudden severe abdominal pain, and it rapidly progresses to hypovolemic shock. That means it gives hardly a time of 15 to 20 minutes. But in the case of retroperitoneum, the aneurysm might rupture in the lateral or the posterior aspect. Here the rupture happens on the posterior part or on the lateral part. Here retroperitoneal space is a huge cavity. Lot of blood can get accumulated before it goes into an hypovolemic shock. And another important thing is, since it gives space for large amount of blood to go through, sometimes a clot might go and seal the rupture. So it can present as a concealed hemorrhage with lot of hypovolemic shock. Now coming to the pre-op preparation. First and foremost is smoking cessation. You have to ask the patient to stop smoking. By stop smoking, you can slow down the aneurysmal growth by 15 to 20%. And another important thing is, it can improve wound healing and reduce the cardiorespiratory complication. Statins and low dose aspirin will be always started when patient is diagnosed with abdominal aortic aneurysm. It also helps to reduce the aneurysmal growth. And another important thing is, it also reduces the cardiovascular complication. Beta blocker and angiotensin converting enzyme should be considered when patient has high cardiovascular risk. But the most important thing which you do in the preoperative period is the blood pressure control. You should not allow the blood pressure to go up because it might rupture the aneurysm. Coming to blood investigation, you do a basic hemoglobin, blood urea nitrogen and creatinine to assess the renal status, blood sugar and HbA1c to know the diabetic status, arterial blood gas, particularly the patient might be a smoker and might have COPD. So you have to assess the oxygenation and carbon dioxide level, and if possible, if the aneurysm is not too big, also do a PFT, coagulation parameters and thromboelastogram for bleeding parameters. Now coming to imaging modality, the first imaging modality which we do is ultrasound abdomen. In ultrasound abdomen, the abdominal aorta is identified by what is called the seagull sign. Here, this is called the seagull sign. That is nothing but celiac artery giving rise to splenic and hepatic artery. Here you can see the seagull. Once you identify that, just if you go lower down, you can see the infrarenal aorta. Here you can see the large aneurysm with measuring around 6 centimeter with the thrombus inside the aneurysm. This is the first imaging modality we do. In the ultrasound, another important thing which we observe is vertebra in the posterior part, and here you can see the inferior vena cava. These two structures also you identify along with the abdominal aorta. Now coming to the gold standard, which is CT angiogram. Here you can locate the entire aneurysm along with the thrombus and the lumen, and you can see the calcification. The most important thing is you have to look at the adjacent vascular structure like celiac trunk, superior mesenteric artery, bifurcation, iliac artery, renal vein. Not only that, you can assess the adequacy of the repair in the post-operative period with the CT angiogram. Here, a post-stent placement, you look at the vascular lumen integrity along with the branch vessels. The cardiac status, you assess with the 12-lead electrocardiogram, and echocardiogram comes in handy when the patient has coronary artery disease. You have to look for regional wall motion abnormality in the preoperative period. This regional wall motion abnormality will be very important in the intraoperative transesophageal echocardiogram because you have to compare the regional wall motion. Now coming to the scoring system, we have various scoring system for abdominal aortic aneurysm, but the most commonly used is the Hardman index, where they look at 5 variables with each having 1 point. The first is age greater than 76 years, creatinine greater than 190 millimole per liter, patient being anemic, hemoglobin less than 9 gram per percentage, and the presence of HEBI on electrocardiogram. That means the patient is ischemic heart disease and history of loss of consciousness on hospital arrival. So there are 5 points. The presence of even 1 point increases your operative mortality to almost 40 to 50%. Then imagine if there is going to be 3 to 4 variables. The mortality is almost 80 to 90%. Even one presence of one or more variable will consistently increasing the mortality. Coming to ruptured aortic aneurysm, we have Dutch aneurysm score, Harbour View Medical Center score, and vascular surgery group score. But what is common here is, although there are many scores available, the operative mortality for ruptured aortic aneurysm is 70 to 80%. Now coming to the management. There are two major modality of management. One is endovascular repair and another is open surgical repair. Nowadays, most of the physicians prefer endovascular placement. With regard to length of stay, 30 days mortality, major adverse event and 1 year survival, definitely endovascular placement scores over open surgical repair. But the problem with endovascular repair is you have to fulfill certain criteria for the procedure to be done. The first and foremost is there should be no iliac artery or aorta tortuosity. Next is your iliofemoral artery, the femoral and the iliac artery should be of sufficient length so that the sheath and the stent can pass across the aneurysm. The aneurysm should not be too big. It should be between 5 to 5.5 centimeter, and the critical side branches, the renal artery branches, should be preserved. It should not be involved along with the aneurysm. And finally, the distance from the renal artery, proximal neck length, should be greater than 1.5 centimeter, and the degree of angulation of the aneurysm should be less than 60 degrees. These criteria are required to place in a stent across the aneurysm. If you look at an animation of how endovascular placement done. Here you have the aneurysm. This is the iliac artery. Your aneurysm is there. Now through this, the guide wire pass across the aneurysm. Here you can see the guide wire is passed. Next, through this, the sheath will be passed. Once the sheath is passed, you place the stent across the aneurysm, and there is a small hole here for the contralateral limb to come, through which the guide wire is passed, then the sheath is passed. Then you have the iliac limb from the contralateral side placed across the stenting. This is how an endovascular placement of the aneurysm is done, and you can see the blood flow established and the blood flow is prevented across the aneurysm. Here you can see the ipsilateral stent placement, small aneurysm. This is the contralateral one, and later you can see the small hole for the contralateral limb, to which another iliac limb will be placed. This is the small saccular aneurysm, 3 centimeter saccular aneurysm, where stent was placed in the postoperative period. And this is a huge aneurysm which also involved the renal artery, and we put a chimney graft to the renal artery also. Now coming to the anesthesia part, the option is very minimal. You have to go with general anesthesia with supplemental epidural. But during positioning, you have to be really careful, because when you change to lateral or sitting position, the thrombus inside the aneurysm might get dislodged and cause occlusion of renal or mesenteric arteries. Apart from that, there is problems of anesthesia outside the OR environment. This is going to be a long duration procedure, and there might be a prolonged bilateral femoral occlusion, and there might be a requirement of short period of apnea during stent deployment. And there is always a small chance of it might be converted into open procedure. Now coming to surgical approach. You have peritoneal approach or retroperitoneal approach. This peritoneal approach, you can put a longitudinal incision or a transverse incision. Coming to retroperitoneal approach, we go near 10th rib. Okay, and you put the incision little at the higher level, that is R2 if renal involvement is there, or at a lower level if iliac artery is involved. First, you have to excise the 10th rib, and you have to identify all the major vascular structures. Here you are identifying the celiac trunk, superior mesenteric artery, renal artery and renal vein. These are all the important vascular landmarks which is required to identify the before you going for clamping here. Then inferior mesenteric artery and the bilateral iliac artery. Then you place a conduit from the upper part of the normal aorta to the bilateral iliac artery. This is how you go for surgery. These are all the surgical part of the aneurysm repair. If you go by animation, you have to locate at the aneurysm part, and this is the, you have to locate the renal artery. You have to place a clamp infrarenally and bilateral iliac. You open the aneurysm, remove the clot and dead tissues. Then you place a conduit between the normal aorta and the bilateral iliac artery. Once you stitch it, you remove the clamp and allow the blood to flow into the iliac artery. This is how a surgery is being done. This is one of the intraoperative pictures. Here you can see an angry looking aorta waiting to rupture. You make a transverse incision, you make a longitudinal incision across the aorta, open it up. Here you can see the aneurysm is being opened up, and here you can see the blood gushing out. Although the clamp is put, the clamp is here, and here you can see the thrombus is being removed. Once thrombus is being removed, then you put the conduit from the upper normal aorta to the lower normal aorta if there is a sufficient space between the iliac artery. If sufficient space is here, you can put a simple conduit. Or if the lower part of iliac is involved, you put a what is called iotobiliac grafting. Now coming to anesthesia management. Here the anesthesia challenge is mainly on the acute hemodynamic changes which happens with clamping and cross clamping, maintaining organ perfusion, partly to the kidney and the intestine, also the lower limb, maintain myocardial oxygen demand supply. Most of the patient or elderly patient might have some form of coronary artery disease and the lung may also might be compromised. So maintaining oxygenation is one of the most important anesthesia goal. You have to attenuate the ischemic reperfusion injury while releasing the clamp, and another important thing is provide a good perioperative analgesia. Anesthesia is usually maintained with the balanced anesthesia technique with high dose opioid, oxygen air mixture, low dose volatile agent, and don't forget thoracic epidural, which might come in handy in the post operative period. Coming to monitoring, we have to go to a standard monitoring of ECG in lead 2 V5, then pulse oximeter. If possible, one pulse oximeter at the distal part to know the adequacy of perfusion. Regarding arterial line, we have to go with right radial. If possible, if aneurysm is large, go for a distal arterial line like dorsalis pedis, so that adequacy of perfusion can be tested once the repair is done. A central venous line is always put. This can be used for volume resuscitation as well as measuring central venous pressure, and sometimes for starting inotrope and vasoconstrictor. And this open heart surgery will lead to lot of temperature loss. So temperature monitoring is a must. Again, urine output, because of renal involvement, sometimes you have to definitely monitor the urine output. And transesophageal echocardiogram will come in handy if the patient has coronary artery disease. You have to look for new regional wall motion abnormality. Heparin 100 units per kg should be given just before applying the clamp. As I said earlier, there is going to be loss of temperature in open abdominal surgery. So you have to use force air warmer, fluid warmer, and increase the theater ambient temperature. And the fluid management should be goal directed. And regarding hemorrhage and blood management, try to maintain the hemoglobin more than 9 gram per deciliter. Now coming to 3 level of placement of clamp. Here you put the clamp just below the renal arteries. So what happens? The blood can go into the renal artery, into the celiac axis, as well as into the thoracic aorta before going into the coronary circulation. By putting the clamp infrarenal, there is not much hemodynamic disturbances. When you place the clamp just above the renal artery, that means a suprarenal clamp. Okay, here the renal artery doesn't receive blood flow, so you have to finish the surgery fast. But what happens? Blood can go into the celiac collateral as well as into the thoracic aorta before reaching the coronary circulation. Again, here there won't be much hemodynamic disturbances, but your renal function might be compromised. If you put the clamp in the supraceliac part, that is where all the problem starts. Your renal artery, this is supraceliac, your renal artery is compromised, your intestinal mesenteric vasculature is compromised, and there is no alternative for this blood. It goes back into the coronary circulation and the heart, and your heart get distended, particularly if your function is already compromised. Here there is going to be lot of hemodynamic disturbances. To make into the hemodynamic part, you can apply the clamp at 3 levels: infrarenal, suprarenal, or supraceliac. When you placed infrarenal, the ejection fraction is not altered. Suprarenal, there might be slightly more decreased ejection fraction than infrarenal. But in supraceliac, you can see the ejection fraction is almost decreased by around 40%. And if you look at the regional wall motion abnormality, there is nothing much with infrarenal. Again, 1/3 of the patient in suprarenal had some form of new regional wall motion abnormality. But look here, in supraceliac, there is lot of patients who came with regional wall motion abnormality. So there is going to be a significant hemodynamic disturbance with supraceliac clamping. And to be on the hemodynamic side, what is going to happen with the aortic clamp? There is going to be increased preload and increase afterload because there is resistance to blood flow ejection. Both this leads to your increased cardiac output and increased blood pressure. Not only that, there is going to be a vasoconstrictor release and central hypovolemia, which might increase your cardiac output and blood pressure. How we are going to counter it? Here, the option is very minimal. You have to go with the vasodilator infusion of nitroglycerin and nitroprusside and reduce the blood pressure. But again, you have to be very careful in not reducing the blood pressure drastically. Coming to unclamping, here the reverse is going to happen. Your preload is going to come down, your afterload is going to come down, and your blood pressure and cardiac output is going to drastically fall. So what you are going to do, you volume load the patient just before the release of clamp. Keep infusion of vasoconstrictors ready in case the pressure is too low. Treatment of metabolic abnormalities like hyperkalemia and acidosis. And most important thing is gradual release of aortic cross clamp. You should not suddenly release. You should gradually release it. And in case of resistant hypotension, you should reapply the clamp. Coming to renal failure, the risk factor is going to be application of suprarenal clamp above the renal artery, prolonged clamp type, and duration of hypotension. The hypotension duration, if it is going to be greater than 5 to 10 minutes, massive hemorrhage, elderly age group, and injection of contrast during CT angiogram. These are all the risk factor for renal failure. Coming to the incidence is around 5.4%, of which 0.6% requires hemodialysis. We think by placing an infrarenal, the renal is not compromised. But we have to understand that even with infrarenal clamp, there is a 40% decrease in renal plasma blood flow. How this happened? It's through renin angiotensin axis. Loop diuretics, dopamine, mannitol, phenethylamine, N-cysteine are all proposed renal agent. There is no level 1 evidence to support their use. Ultimately, what you can do is adequate fluid resuscitation and avoidance of nephrotoxin. Coming to the intestinal part, your inferior mesenteric artery is almost always sacrificed, but usually nothing happens because there is a rich collateral between celiac, superior mesenteric, and inferior mesenteric. Coming to the post-operative period, usually when there is no untoward incident in the perioperative period, you can extubate the patient on table. But if you think patient has some hemodynamic disturbances or some bleeding, always the patient is going to be shifting to intensive care. So you can wait for 1 or 2 hours and then extubate. Epidural analgesia can be started for pain relief. And once extubated, you have to go for early post-operative mobilization and physiotherapy. And don't forget the prophylaxis against deep vein thrombosis. These are the various papers written by me. This was a review article in Annals of Cardiac Anesthesia in 2015, where we wrote about various anesthetic consideration for endovascular abdominal aortic aneurysm repair. And this was a quite interesting case where the adult coarctation in the postoperative period changed into an aneurysm, and we had to go for deep hypothermic circulatory arrest to do the case. And this was a case of infected aortic processes where we created a conduit from thoracic aorta to bilateral femoral arteries. And this was one of the youngest case of ascending aortic aneurysm in a 7-year-old child. And this was published in Cardiology of Young in 2014. So to conclude, smoking, old age, and male sex are the 3 important significant risk factors in abdominal aortic aneurysm. In the preoperative period, even in the perioperative period, blood pressure control is very, very crucial in the management. Mortality rate is very high after rupture or an emergency repair. Nowadays, all the physicians prefer endovascular placement than surgical repair provided the criteria for endovascular placement is met. General anesthesia with thoracic epidural is always preferred. Hemodynamics can be really challenging during clamping and unclamping. Transient renal dysfunction, bowel movement impairment, and bleeding should be always anticipated. Thank you.
Thank you, sir, for the excellent presentation. You well described about etiologies and pathogenesis and what happens during and after surgery. As in nutshell, it's basically it's one of the challenging case for us. There should be a fine balance between the increased afterload at the same time, as many of the patients are probably ischemic heart disease patients. They may not tolerate, which may leads to, as sir suggested, regional wall motion abnormalities, and also the major issue is if too much fall in blood pressure can compromise the cardiac perfusion. So we have to maintain fine balance. We can take some questions or some suggestions from the senior faculty.
And Shyam will answer.
Good evening, sir.
Please go ahead.
Hello, sir.
Yeah.
Such a wonderful presentation, sir.
Thank you.
I have two questions, sir. One is regarding the myocardial protection. If we have a patient who is already having an active cardiac condition, can we have some preoperative drugs like ACE inhibitors or beta blockers? What is your take on that, sir?
Yeah,
Next
specifically clearly mentioned that beta blocker and ACE inhibitor, any cardiac risk patient, you have to consider taking it. Okay,
yes, sir.
no doubt about it at all. And you should have all the invasive line TOE ready and manage accordingly. If needed, you have to go for advanced hemodynamic monitoring where you can look at the SVR, PVR, and those things also. Okay, then you can manage your volume status and give the inotropes or vasodilators which is required. Accordingly, you can manage the patient. Definitely, any cardiac risk patients, you have to go for an aggressive hemodynamic management with more advanced hemodynamic parameters.
Okay, sir.
Do you want to continue the AC inhibitors who are already on the day of surgery?
According to the guidelines in vascular surgery, which is going to lead to hypotension, discontinue and restart as early as possible. Okay, that is the guidelines given. If infrarenal, where there is not going to be much of hemodynamic disturbance, you can continue. But suprarenal or supraceliac, where you anticipate some hemodynamic disturbance, better discontinue and restart as early as possible. That is what my take on that.
Yes, sir.
Maybe somebody senior can advise on that.
Okay. One more thing. How do you manage the metabolic acidosis post unclamping, sir? Sometimes it's so severe it lasts a very long time in the post-operative period. Is there any specific?
I am not very fond of always infusing bicarb just before the release of clamp or after release of clamp. Okay.
Yes, sir. Yes, sir.
Definitely acidosis will be there within 3 or 4 minutes. See, definitely once you infuse enough volume, not necessarily soda bicarb. If you infuse enough volume, automatically it settles in 3 or 4 minutes unless it is crossing some severe hemodynamic disturbances. Okay, if acidosis is causing severe hemodynamic disturbances, then consider soda bicarb. But if acidosis is not causing much hemodynamic disturbances, just hold on for 3 or 4 minutes. Everything will fall back to normal and it should be fine. Usually, I won't give soda bicarb unless it is causing hemodynamic disturbances.
Thank you very much, sir. Thank you, sir.
Any comments from the senior faculty? So Gopinath sir and
No, he has covered it extensively.
Yes, excellent.
Wonderful. I think some small issues are, there is always hemodynamic perturbations, brief hypotension. So especially in the elderly and at cross clamping, there has always been a small higher incidence of neurological dysfunction in these elderly patients. So this has to be borne in mind if the patient doesn't wake up or has altered this function post-op. So one should always, so hemodynamic monitoring is extraordinarily important. Obviously, managing blood loss. So if you have a clamp in place, so elective surgery, it is, it's well planned. So you have time for everything, you have planning. It's only the emergent situation that can be absolute mayhem, including, severe hemodynamic disturbances as well as blood loss and coagulation. So I'm sure there will be another big class by Dr. Ranjit for all that. But nice class, Dr. Ranjit. Thank you.
Thank you so much, sir. Coming from you makes me happy, really.
Yeah, it's very nice presentation, Ranjit.
Thank you, sir. Thank you so much.
I feel the crucial period, very brief period after unclamping of these period after unclamping is most important. How to manage that, especially if it is suprarenal areas.
No, that's what I said in the monitoring,
Yeah,
sir. You have to go with the TUE to
that
monitor the
period.
cardiac status and advanced hemodynamic. You have to go for some volume indices with the advanced monitoring, whether stroke volume variation or something. Then look at the volume. You have, if the volume is low, sometimes they look at the IVC diameter or SVC, is stroke volume variation, everything. You can give volume accordingly and look at the contractly, regional motion abnormality or something. Accordingly, you go for an inotrope or something, sir.
Right.
That's what I do.
That is the period which is more
understood
to us.
Yeah.
So we'll move on to the
We'll
next.
move on to the next, Dr. Shyam.
Yes, sir.
Thank you, Dr. Shyam, and thank you, everyone.
Thank you, Dr. Karthikeyan. Thank you very much.
Yeah.
Very informative.
Yeah.
This will be given by Professor Nishant Kumar. He is from LH Medical College, New Delhi. His areas of interest including critical care, focus, and ultrasound and regional anesthesia, TIVA, and research methodology. He published nearly 14 publications in index journals. He's also an associate editor for IJA. Has been peer-reviewed many journals. With this, I welcome Dr. Nishant Kumar to start his session. Dr. Nishant?
Okay.
Hello, good evening. I'm sorry for the bad connection. Am I audible?
Yeah.
Am I audible? Yeah, I'm sorry for the video because I'm traveling. Sorry, I had an appointment. So I'm traveling. So I'm sorry for the video. So the topic for today is anesthesia for interventional pulmonology. When I heard of this topic, I was a bit taken aback myself because this is a very novel topic. And although we do get the procedures done, so that got me reading, and I was surprised at the gamut of the procedures that are being done by the pulmonologists nowadays. So basically, we all know that with the increase in carcinogens all around us, with the bad air that we are breathing and the bad habits that we have all cultivated, there's an increase in benign and malignant lesions of the tracheobronchial tree, not necessarily carcinoma, but other diseases also. And with improvements in the diagnostic modalities, even the smallest lesions are being picked up, and with the people becoming more aware of their health status, they are seeking help early. So basically, the pulmonologists divide their procedures, can be divided into two broad categories. That is, one is diagnostic and the other one is therapeutic. Now, most of these are now being done non-invasively or minimally invasively. But at the same time, since it's a tracheobronchial tree, I mean, if you imagine even a small drop of water or small grain of rice, when it enters our trachea or the respiratory tract, it causes a bout of coughing and it causes so much of discomfort. So imagine a thick, even a flexible bronchoscope smeared with lignocaine jelly passing through your trachea, how much discomfort it will cause to the patient. So the requirement of anesthesiologist is a paramount necessity for these procedures, more so for the therapeutic ones. But yes, at the same time, there are certain concerns that we have to be aware of, and we should be aware that these procedures, even the simplest of these procedures, are not without risk because it involves the airway. Now, these procedures are usually used to be carried out in the operating room, but nowadays there are specific bronchoscopic suites, which are merely rooms with the equipment used by the pulmonologist, with very little or less support for the anesthesiologist, or a hybrid OR, in which it's basically a bronchoscopy suite with an anesthesia machine. And you have to be careful of all the concerns of non-operating room anesthesia. So the procedures, as I said, range from diagnostic to therapeutic and may require monitored anesthesia care, a simple topical anesthesia, regional anesthesia, or even general anesthesia, including a double lumen tube. So since, as I said earlier, there are a lot of procedures which are being done now, and the familiarity with what the pulmonologist is going to do is a must, because that is when you'll anticipate that what the pulmonologist is going to do, what is going to be the comfort level of the patient, how do you plan your anesthesia, what are the possible complications, and how you can maximally assist the pulmonologist without causing much inconvenience to the patient himself, and keeping yourself ethically and medically safe. So coming to the procedures, the simple procedures, diagnostic bronchoscopy, which can be a flexible or a rigid bronchoscope. Then we have the transbronchial needle aspirations, which can be blind, which can be through the flexible bronchoscope, through the rigid bronchoscope, even CT guided. Then we have the pneumatic bronchoplasty, where we have the dilatation of the airways, which have stricture or a tumor, trachea. Then laser photocoagulation or laser argon coagulation of the lesions. Then there is insertion of the specific one-way valves for volume reduction in emphysematous patient. Cryotherapy and argon plasma coagulation, as I said earlier, mechanical dilatation of the strictured airway, tumor debulking. If there's a tumor sitting there, most scary of them are the ones which are sitting right above the carina, foreign body, most commonly seen in the pediatric airways. Electromagnetic bronchoscopy and the endobronchial ultrasound, which are targeted therapies for very small lesions lying in the periphery of the lungs and the pleura. Then you have the procedures, fluoroscopic, augmented fluoroscopy, and CT guided procedures in the CT bronchial thermoplasty. Just give me a minute, please. And we have the bronchial thermoplasty, which is reduction of the airway strictures in asthma. So that is also, since it's a thermoplasty, there will be discomfort to the patient and anesthesia has to be provided. So as for all anesthesia procedures, you have to do a thorough pre-anesthetic checkup, patient history examination has to be done. You have to see what are the comorbid conditions that the patient has. And since the airways are involved, certain amount of optimization in the form of bronchodilators, the therapy, and incentive spirometry investigation pulmonologist as to what exactly the pulmonologist is going to do. What is the procedure? How long will it take? What is the nature of the invasiveness? All this has to be communicated with the pulmonologist. A good communication will lessen half your tension and give you half the suit, the bronchoscopy suit. It has to be prepared. There should be facility for all topical, regional, GA, including TY and DCI, the difficult airway cart, and the resistant cart are a must. You should have a defib in place. You have the facility for front of neck access, and patient should be informed regarding all the risks. So written informed consent has to be taken for the procedure itself, the loss of airway, which can occur at any time, emergency front of access, and the complications that may arise because of the procedure. The anesthesia technique has to be discussed and explained to the patient and the pulmonologist in advance. It is always better that if you do so, and remember that you should always have a plan B and a plan C to fall back on. So that is how you do. So that is all you have to do before you take up the patient. So as I said, a description of what all is done. So we know that flexible bronchoscopy, it's a diagnostic assessment of dynamic central airway collapse. We do the endobronchial biopsies for the evaluation of the endobronchial lesions, bronchoalveolar lavage. Now, this can be tricky for the analysis of alveolar contents because at times large volumes will have to be instilled and that may cause discomfort to the patient, even causing hypoxemia and hypercarbia and causing collapse. In fact, in alveolar proteinosis, which is one of the most difficult procedures, you might even have to go in for a double lumen tube so as to prevent the soiling of the normal lung. So we have the transbronchial biopsies, brushings. We have the conventional needle aspirations. In the advanced diagnostic procedures, we have the endobronchial ultrasound, guided needle aspiration. Now, for this, is basically for mediastinal and or hilar lymphadenopathy and lesions which are at the periphery. Now, a certain thing is required, something is known as electromagnetic navigation or virtual bronchoscopy, in which the 3D model of the bronchoscope is constructed based on the CT scan, and you have a real guided, there's an electromagnetic probe in the flexible bronchoscope also. And this is basically used for very small, targeting very small lesions. And this is real time, and patient movement has to be avoided in this. Then we have the cryobiopsy, where we use for the airway or parenchymal tissue sampling, and the nodule access. Again, rigid bronchoscopy, we all must have, we all have gone through it before the advent of the flexible bronchoscope. This was the main modality, even for foreign body removal. Rigid bronchoscopy remains the choice for stent deployment and massive hemoptysis. Again, rigid bronchoscopy and coagulation may be required. For stent placement, it is usually the strictures or because of the secondary or malignancy or benign disease. So we have the Salis 6 stents and the metallic stents. Ablation techniques, again, laser, electrocautery, argon plasma, cryotherapy, spray cryotherapy, and all these things. So all the precautions that you take for a laser procedure have to be taken. Bronchial thermoplasty, as I said, is used for severe asthma, wherein the intima of the airways is ablated so that the diameter is decreased, the diameter is increased, causing bronchodilation. Placement of the interbronchial valves, as I said, for emphysema, lung volume reduction surgery, and the coil placement or stream placement interbronchial for this thing again. Now, coming to the concerns, what are our concerns when we take up these patients for these particular procedures? Now, the concerns can be divided into the patient-related, the place-related, and the procedure-related. The patient-related are that often these patients have multiple problems. They are dyspneic, they have stridor, they are hypoxemic or hypercarbic. Often they can be classified as ASA 3 and 4, often been taken as emergency procedures. They have airway obstruction and limitation. Place related. Now, as I said, if the procedure is being done in the OR, you're still familiar with it. But if it's a bronchoscopy suite or if it's a hybrid OR, then you are away from the usual place where you're used and where your things are there. So you have all the concerns regarding non-operating room anesthesia. You have less people. The help is away. You don't have your usual drugs and equipment at hand. And if there's a problem, if there's a catastrophe, then you might find yourself in soup. So all these things, it is always better to inform your colleague that, okay, I'm there, I might need you for help, and keep help available at a phone call away. Now, the most of the problems are usually procedural.
Audio is not coming.
audio is stopped, Ramakrishna.
Sir, maybe he's in.
Ramchandran?
He's traveling, sir. Just a few seconds. We may get back to him again.
Okay, okay.
He has some emergency appointment. Probably is going from home to the probably particular near the hospital. Dr. Nishant?
The audible?
Yeah,
Yes,
yeah.
Nishant.
Now,
Yes.
just now it has come.
Hello,
Yeah, yeah.
No,
You are
no, it's
audible.
audible.
I'm audible now.
Yeah.
Okay, sorry. So I hope I have not missed out any part. If I am willing to repeat it.
Continue. No, that's okay. You can continue from here.
Okay, fine. Thank you. So I think there was a signal loss. As I was saying that usually under topical anesthesia and mild sedation, it is always better to give angiolysis. And if the patient is well preserved, you can go in with midazolam and fentanyl. Even dexmedetomidine has been used nowadays. Always better to give administer glycopyrrolate so that the field is dry. The pulmonologist is happy, and you are happy that the secretions are not causing any airway reactivity. So if it's the route is nasal, you decongest the nasal cavity. The first thing is that you determine which is the dominant nostril, and then administer otrivin drops, xylometazoline drops, and then we can use xylocaine jelly. And for the oral cavity, it is 10% spray and viscous gargles. Be sure that there are a variety of blocks also. You can give hypoglossal glossopharyngeal block, glossopharyngeal block, and the suprahyoid block for the nerves of the larynx. Then you can use 4 ml of 4% lignocaine nebulization, which anesthetizes the entire airway right from the nostrils till the tracheobronchial tree. The spray as you go technique, or the oldest technique, which is a transtracheal. My personal favorite, unfortunately, even in this tray, remains a transtracheal with the residual I cover up with spray as you go, along with the viscous gargles. So you might require additional boluses of fentanyl, dexmedetomidine in a loading dose of 1 microgram per kg over 10 minutes, followed by 0.2 to 0.5 microgram per kg. Gives very good analgesia, sedation, and a cool and a calm patient. So dexmedetomidine is now emerging as a very good drug for these procedures. For rigid bronchoscopy or laser procedures are usually done via the rigid bronchoscope. General anesthesia is usually administered. EtCO2 is a must. Now, there are 2 ways. Some people go in with inhalational anesthesia, some people prefer TIVA. Now, TIVA can be small boluses of propofol as and when required. It can be target control infusion. It can be a Bristol technique or a fixed infusion. Along with propofol, you can use fentanyl, ketamine, dexmedetomidine. The advantage with ketamine is that it offers further bronchodilatory properties, plus the SVR and the BP is maintained. Dexmedetomidine may cause bradycardia, hypotension, and the bradycardia may be confused whether it is because of the drug per se or because of hypoxia. So maybe, but it is being increasingly used. Muscle relaxation, again, the use of scoline versus long-acting rocuronium. Intermittent scoline was used when I was doing my post-graduation. However, because of the chances of phase 2 blocks, no longer in practice. Ventilation is usually conventional. Either you can use you can attach the JR circuit to the ventilating bronchoscope, which the pulmonologist is using on that. Or what you can do is that you can give 100% oxygen, paralyze the patient, give 100% oxygen. Once the saturation is up to 100%, let the pulmonologist proceed. And as soon as the saturation touches 92, you take over and again ventilate through the bronchoscope. So I prefer using a ventilating bronchoscope. The problem is that EtCO2 usually rises, so the pulmonologist has to be quick. Wherever there is available high frequency jet ventilation with a rate of 120 breaths per minute, low tidal volume, high frequency breaths can be used. Again, hypercarbia is a concern with that. So we'll come to the gray areas and the controversies in the coming slides. But yes, there are many ways how you can actually carry out this particular procedure. For fluoroscopy or non-intubated thoracic surgeries, usually regional anesthesia suffices. Now, again, we have got a wide variety. We can use the blind thoracic epidural, the age-old technique, USG-guided paravertebral block, either single shot or catheter. It can be given blind also, loss of resistance there or saline. We have the erector spinae block also, which works wonderfully. Now, again, either as a single shot or a continuous technique with the catheter and ultrasound guidance. If you're not a fan of regional anesthesia, or if the procedure is short, the lesion is quite within reach and the pulmonologist has experience, you can use again propofol, fentanyl, ketamine, dexmedetomidine in the doses that I've described above, either as boluses, intermittent boluses, or as infusions or in PCI. So these are actually the various ways that you can provide anesthesia. Now, what are the controversies? So whether you should go in for operating room or bronchoscopy suits. Now, the only difference between an operating room and a bronchoscopy suit is the equipment and the help. So in OR, you usually have your workstation. Bronchoscopy suits, if they have a workstation available, then it becomes a hybrid OR. So I would go that I would always err on the side of safety. So I am most comfortable when a workstation is available. GA versus MAC or sedation will depend on the complexity of the procedure, the cooperation of the patient, and the time duration required by the pulmonologist. So if it's a deep lesion, if the patient is not cooperative, and if the patient is required to be immobilized, I'll go in for a GA. If it's a superficial lesion, the pain, it is less painful and the patient is cooperational, I'll probably go in for MAC versus sedation. TIVA versus inhalation. Now, all the societies, they recommend that TIVA is the anesthesia of choice. But the institute where I practice, in fact, apart from me, everyone else uses inhalation. Now, one of the disadvantages of using inhalational anesthesia is that the inhalational drug that we most commonly use is sevoflurane. Now, the problem with sevoflurane is it is quick in and quick out. So if you're using through a rigid bronchoscope during the apnea time, the sevoflurane is exhaled and the patient becomes lighter. TIVA, on the other hand, gives stable hemodynamics, gives a continuous depth, and the crescent troughs are much lower. But yes, the proponents of inhalational, they counter that the wakening is a bit delayed. So I would say better to have a 10-minute delayed wakening rather than having crescent troughs, BP shooting up, BP going down, and you fidgeting, okay, patient is waking up, pulmonologist struggling. So I would rather have a 10-minute delay rather than going with the inhalational agents. but each to its own. But the recommendation is now TIVA. So use of relaxants, scoline versus long-acting rocuronium versus no relaxant at all. So my personal choice is I don't use relaxants unless until absolutely required. Rocuronium, the advantage is now the Sugammadex is available in India. So even if there's a deep block, you can easily reverse it with Sugammadex. Supraglottic device versus endotracheal tube. Now, if it's a deep lesion, I would definitely prefer an endotracheal tube. The problem is that the scope has to pass through the same airway. So either it will pass through the endotracheal tube or by the side of the endotracheal tube, which will again necessitate putting in a smaller tube. So that will cause resistance, whether you're passing the scope through the tube or you're passing the scope by the side of the tube, the resistance will be increased. Supraglottic devices are beneficial when a flexible scope is being used. So you give a relaxant, you put in a supraglottic device, and the scope simply can be negotiated through the cords with the ventilation being maintained. Midazolam versus dexmedetomidine, I would prefer dexmedetomidine, but if used for a longer period of time, may cause bradycardia, hypotension, and delayed awakening as compared to midazolam. Midazolam is usually given as a bolus, not as an infusion. Dexamethasone is usually administered preoperatively to reduce edema, intraoperatively also, and postoperatively also. Now, this is a concern, especially in diabetics, which most of these patients are, that it will raise the blood sugar levels. But yes, they can be managed. The benefits of dexamethasone are much more than those of the increase in blood sugar levels. So coming to the complications that you can face, the first and the foremost is loss of airway, hypoxemia because of that, laryngospasm, specifically if you have not used a relaxant or the airways are reactive, the endotracheal tube is not in situ. It can occur in an awake patient also, and it's usually troublesome. So first thing, the basics, you increase oxygenation, increase the depth of anesthesia, and usually 0.1 milligram of scoline, 0.1 to 0.2 milligram of scoline relieves that, or the Larson's maneuver. So that usually relieves laryngospasm. Bleeding can be catastrophic because then the field of view becomes obscured. You're in a panic, specifically with the flexible devices, but there's not much that you can do except instill maybe a bit of diluted adrenaline. So if to locally vasoconstrict the arteries or the vessels till the pulmonologist finds the source of the bleeding. Device malfunction. Now that can be really scary if you're using a ventilating bronchoscope, the circuits, the disconnections, and usually the pulmonologist is standing at the head end. You've given the entire unprotected airway to the pulmonologist, and on top of that, if there's a device malfunction, then that is really scary. So you please make sure that you check all your devices, make sure how it will work, where all the connections go, and maintain them. Airway edema in the postoperative period, yes, that's a real problem. So you have to take care of by steroids. Pneumothorax and surgical emphysema can occur anytime because of the intervention by the pulmonologist. Keep a high degree of suspicion, keep an ICD ready, and needle aspiration should be ready. Local anesthetic systemic toxicity. Now we are using large doses of local anesthetic for spray as you go technique, for nebulization and supplementation. So 10% your fat should be available for last, and atelectasis now again is a common complication which can be countered by recruiting the lung volume, giving high PEEP, pre-oxygenation, intensive spirometry in the preoperative period. Now again, general anesthesia to be avoided. You maintain a bit of PEEP, and then post-intubation, you see that if the PEEP is required, you inflate and recruit the lung during the intraoperative period. And what you do is basically you breath hold during the peak of inspiration rather than expiration. You hold it not at a very high pressure, but at the normal tidal volume pressure. And you have to minimize the movement of the lung while the pulmonologist is at a particular stage. So these maneuvers can be done when the pulmonologist is close to the lesion or close to the foreign body, that is the time when you have to provide apnea and prevent any movement of the lungs. Post procedure, you have to exclude pneumothorax and assess any residual electrolysis at all times during intraoperative period. Ensure that you use minimum amount of oxygen to maintain saturation above 92%, 92 to 95%. Please, I personally don't advocate the use of nitrous oxide. Use air as a diluent, and for laser procedures, please keep a bucket of water ready and specifically use the laser tubes and all the precautions that are advocated for laser procedures. So that is my talk, and I'm open to questions. Thank you very much.
Thank you, Dr. Nishant. It was a well described presentation. And I have
Thank
few
you.
questions, like especially nowadays, with the increasing technology in the surgical colleagues, and many people are opting for severely compromised airways coming for debulking surgeries.
Yeah, true. Those are the most scary ones, sir.
So what your take, like many centers are opting for awake jet ventilation under ketamine or dexmedetomidine,
Yes.
other agents. So what is your routine way of doing things in your place?
See, I usually, ketamine can be a double-edged sword. The problem with ketamine is that it can quickly lead to loss of airway, although it is a very good bronchodilator. But then because of the delirium associated with ketamine, although even if you pre-medicate with midazolam, the reactivity increases, the secretion increase. So I usually prefer a combination of dexmedetomidine and propofol for these patients, maintaining spontaneous respiration. Now, for these particular procedures, spontaneous respiration maintenance is a must. And analgesia, dexmedetomidine provides fairly good analgesia for these procedures.
Yeah, one more thing, probably so many centers are nowadays preferring ketamine as well, as we can deal other things.
I've got nothing against ketamine. The only thing is that because of the hypoxia, hypercarbia, and ketamine itself, at times the BP really shoots up, and then if there's a small bleeder, then it magnifies and this thing. But when used with other agents like propofol in combination,
yes,
definitely yes.
Yeah.
But not ketamine as a sole agent. I personally don't advocate.
Yeah,
ketamine.
Not a sole agent, probably combined
with propofol and other agents as a balance anesthesia.
Now
ketamine is excellent.
Nishan, now that more better drugs are available in the market, especially propofol and fentanyl combination, that will work better than ketamine. Ketamine was used once upon a time, but now ketamine for these procedures are little dangerous.
Little dangerous, as I said.
Little dangerous. So you should be used with caution.
Exactly, sir. My point exactly, sir.
Now that you have so many better drugs than that, especially in the form of propofol or fentanyl and dexmedetomidine, when all these are there, probably choice of ketamine would be put as a last.
Probably, sir, especially what is the context where you just have millimeters, like 1 or 2 millimeters of airway is available.
Exactly.
Very debulking surgery. I'm not saying the other situations. In this kind of situation, yes, combination of ketamine still works.
No doubt about that. No doubt about that.
In this area of shared airway, it is the familiarity technique what anesthetist uses and the expertise of the surgeon also counts.
The most important thing, in fact, sir, is the expertise of the surgeon.
Expertise of the surgeon is very important.
Very important.
And how to go about, and in consultation with the surgeon, probably you can plan. There are different modes available, as Nishant has already pointed out. There are so many techniques are available. I have half a dozen to dozen techniques are there. You can choose. Not every patient may not be fit for the same type of anesthesia. Every patient may require a different combination of drug, a different combination of ventilation, and a different combination of drugs.
Nowadays, with the advent of ventilators for jet ventilation, probably the ventilation became relatively much more easier for us. Anybody has experience with the using of these jet ventilators in your setups?
Yeah, I have used in ENT hospital quite many times. We had that was the best option what was available at that particular time.
Okay.
I have used jet ventilation. I have used jet ventilation for laser excision of the
For all the procedures, for all the
Yeah.
endobronchial procedures, we use jet ventilation, especially if you have a ventilating bronchoscope. There's nothing like it.
True. Agree, sir. Agree.
Yes, yes.
Any other comments from the senior faculty, please?
Dr. Nishant.
Dr. Pratap Reddy.
Please.
Yeah. Sham. Dr. Nishant. Yeah.
Hello.
Yes, sir. You
Hello.
can
Should
go
have
ahead, sir.
added one or two
Yeah,
videos.
Sorry?
One or two videos like debulking this
Faculty.
and thoracotomy and the other blocks. You should have added one or two videos also. I think.
I'm sorry for that. Yeah,
The-
I had a
the
images, I
lecture,
had
the
a few
topic is
images
very
of
interesting.
debulking.
It's good.
Yeah. No, we are using regional blocks quite commonly. In fact, we're using paravertebral and ESP very commonly for all the procedures. But yes, I'm sorry for that.
It gives more interest to the
Yeah,
topic.
sure.
Thank you.
Next time, sir,
Yeah.
definitely.
Dr. Pratap Reddy want to ask something? Sir, please go ahead.
No. Just I want to add my experience. We are regularly, because I am now working at Yashoda Hospital, Secunderabad. We are having a hybrid unit, bronchoscopy unit, where we do these kind of procedures on regular basis. Actually, the airway compromised patients, as plan B or plan C, most of the times in sick cases, after having a check bronch awake, and then going through it, and after seeing the check bronch, we'll have this plan B and plan C with us. And in that, we usually, in a few patients, at least 3 patients we did in the last month, we were ready with VA ECMO, keeping as a standby, putting one femoral line, single lumen femoral venous line on one side, and femoral arterial line one side, and then we are going through the regular procedure, putting IGL and then allowing the pulmonologist and whoever is doing the procedure for bronchoscopy. And then while putting the rigid, if something goes wrong, immediately initiating the ECMO. And we saved one tracheal stenosis, severely tracheal stenosis patient like that. And also one patient who had a lot of bleed, and then both lungs were flooded with blood. It was a carcinoid, and the age of that patient was 15-year-old. But keeping the patient immediately on ECMO and then taking up the patient for thoracotomy. And then patient has to undergo right middle lobectomy and then lower lobectomy, and then we could save the patient. And ECMO is also, keeping ECMO as a standby is also one of the better options to actually as plan B or plan C, not as a plan A. Is also one of the good things for these patients to manage. And actually, unfortunately, for one 24-year-old male post-strangulation and then severe tracheal stenosis, as one of the faculty were telling that it's only 2 millimeters or 3 millimeters. He presented to us with gasping, actually. Gasping, fortunately, the ECMO team was there at that time in the morning at 6 a.m. and they were able to initiate VV ECMO, and then we could take up the patient for dilatation, and then we placed a stent, and then we saved that patient. And this is my experience in the last 2 to 3 months with this bronchopulmonary, this bronch unit and then bronch procedures.
So, what is your standard anesthesia, sir, for spontaneous?
Standard anesthesia first one. No, we actually basically for any debulking or even for doing ultrasound and then biopsies, we are actually putting IGLs actually. IGL with or without relaxant, and my favorite combination is propofol and dexmedetomidine infusion, basically. And I stopped using inhalation agent because the drug is getting wasted, and then our pulmonologists are getting headache by the evening. Maybe they are going into a sort of hangover.
It is the anesthesiologist and the pulmonologist who anesthetize more with the inhalation rather than the patient. That is what I believe.
Yeah. That's why I stopped using inhalation agents, and then now I am going with the complete TIVA. If pediatric patient is there, then only I am using.
Same here, sir. Same here.
Then only I am using.
Even for pediatric patients, sir, I am using complete TIVA.
Yeah.
I use Sentinel and Propofol for pediatric patients.
For them only, I am using only 1 milligram per kg ketamine. That's all. Just to make calm down. That's all. Otherwise, For adults, I'm not using any ketamine or anything. Yeah. That is the thing, sir.
Right,
Actually,
sir.
that is the technique I'm following actually right now. Yeah, even today morning also we did both the right main bronchus and then left main bronchus secondary tumors because of the carcinoma ovary. Carcinoma ovary has got treated and then patient came for the second sitting debulking today. Successfully we completed that case. Almost it took 4 hours and then patient is good right now actually.
Right, sir. Right, sir.
Hello.
Sir.
Yes.
No, I concur completely with Pratap because one is theater pollution apart from pulmonologist dropping off or having a headache. The other is obviously with inhaled, you basically spend a lot of money and it's a waste, as you said. Plus,
Yes, sir.
obviously, ECMO is now available, but earlier we used to have pump standby for partial bypass. So that was our
Yes, sir.
way of looking at or managing, major tracheal or airway stenotic or other complications or compromised major airways. So that is something that one has to bear in mind. And obviously, please always have a second person to help you. These are not procedures where you do it on your own. So always have some trained help. I guess all major hospitals would have it, but generally in government setups or other such places, you should always seek some help. That's something you should have in mind. Thank you. Good talk, Nishant.
Thank you.
Very nice.
Thank you. Thank you, sir.
Nice presentation.
Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you so much.
Okay, if there are no more queries, shall we conclude, Ramkrishna?
Yes, sir. Yes. Thank you, both the speakers and
Thank you.
all
Thank you,
the
Dr.
seniors,
Ramkrishna.
including Dr. Gopinath sir and Deepra sir. I think there are no more questions.
Thank you, sir. Thank you so much for
Shyam, we
inviting
can
me.
conclude,
Thank
Shyam.
Yes,
Thank
sir. Yes, sir. We can conclude, sir. I thank all the Dr. Ranjit Karthikeyan, sir, and Dr. Nishant for your excellent presentation and improving, make it more interactive and interesting. Thank you.